Good evening, everyone, and welcome to our musculoskeletal active skills ultrasound Zoom meeting tonight. Of course, we have different time zones. Dr. Andrea is in the US, so good morning, right?
Yes, sir.
In Australia, it's about maybe early in the afternoon, so good afternoon. We also have people from Australia. So we welcome you all to this meeting, and we are so privileged and honored to have one of the very popular author and speaker on pain medicine and ultrasound in the person of Dr. Andrea Trescot. Did I pronounce it well, right?
Fair enough.
Okay. She is the past president of the American Society of Interventional Pain Physicians. She is the past fellowship director at the University of Florida and University of Washington, and the current chief medical officer of StimWave, a wireless stimulation company. Dr. Trescot has authored more than 150 peer-reviewed articles and textbook chapters, and she is the editor and senior author of a 900-page pain textbook on peripheral nerve entrapment. I remember her in Budapest when I asked Dr. Trescot to sign the book for me.
Which I was quite proud to do.
Yeah, and she's also co-author of Pain-Wise, A Patient's Guide to Pain Management, as well as a co-editor of the 3-volume pain review textbook, Pain Medicine and Interventional Pain Management. It is a comprehensive review. And of course, she's very, very dynamic. She speaks everywhere in the world. Name it and she'll have it. I'm so privileged and happy that she accepted our invitation to speak in the Zoom meeting tonight. And I would like to welcome all of you from different parts of the world who are listening right now. And before we begin, let's just offer a short prayer for everyone. Let's pray. Heavenly Father, we thank you for this beautiful evening. We thank you for your goodness and your grace. We thank you for preserving our lives, giving us good health and strength, and protecting us from the COVID infection. And we pray, Lord, for our colleagues who are still there, working and doing a lot of challenging work. Kindly be with them as well. Kindly be with Dr. Trescot, especially as she delivered the lecture tonight. In Jesus' name we pray. Amen. So Dr. Andrea Trescot, MD, FIPP, CIPS, welcome. It's all yours now.
Thank you so much. And thank you for the lovely introduction. And it's quite a pleasure to be with you here today in the Philippines. I've been tasked with the job of talking about the role of ultrasound in the treatment of peripheral neuropathies and entrapments. So let me see. There we go. And so you've already heard what I am and used to be. So the definition of an entrapment neuropathy, oh goodness, sorry. The definition of an entrapment neuropathy, let's try that again. Okay, is defined as a pressure-induced injury to a peripheral nerve in a segment of its course due to either anatomic structures or pathologic processes. This entrapment occurs at anatomical sites, and it is usually where nerves change direction to enter either a fibrous or osteofibrous tunnel, or where the nerve passes over a fibrous or muscular band. And it occurs at these sites because there's a mechanically induced irritation that occurs at these locations. The hallmarks are pain, burning, aching, tingling. There's usually a paresthesia with compression, a Tinel's sign that represents some of the ectopic excitability. And then there's a very important concept of double crush. Because the blood flow from the nerve comes from the spinal cord, if it is partially compressed proximally and then compressed again distally, the effect of that is much more dramatic than either of those would be by themselves. And that's sort of a 1 + 1 = 3. And the idea that you need to be thinking when you're looking at these peripheral nerve entrapments, make sure you're thinking, is there a problem more proximal? So the patient with a foraminal stenosis at C6 and a radial, superficial radial pathology will have much more pathology than if they had just the foraminal stenosis or just the superficial radial pathology. And so so there are tunnels, narrow anatomic spaces, fibrous bands and scar tissue, masses, bony calluses, external compression from braces and casts, and edema, as well as inflammation. Now, we can see this in swelling of the nerves. We can see it in constriction of the nerves under ultrasound. We can see it from things like bone spurs that are distorting the path of the nerve. And we can see it from external or internal compression of the nerve. So the pathophysiology is that prolonged compression causes ischemia due to compression of the vasa nervorum. There's a mechanical deformation of the myelin sheath and impairment of those axonal nutrients, as we were describing. So each of these nerves has its own blood flow, and it's that blood flow that gets compromised, and that leads to ischemia of the nerve, and the ischemia of the nerve leads to pain. Now, these entrapments can occur from the head to the toe, and if you know the cause of the pain, you can actually treat it effectively. You cannot treat what you cannot diagnose. Headaches are not a diagnosis. Low back pain is not a diagnosis. Abdominal pain is not a diagnosis. So once you've made the diagnosis, and ultrasound can help you do that, you then can set up a real treatment plan. And so that means that you can treat the problem effectively. You can prevent unnecessary imaging, unnecessary surgeries, and those surgeries that may actually make things much worse, and other therapies that make things worse. So that knowledgeable pain physician can diagnose and treat these nerves in what I think is the most effective manner. So we need to take a history and physical exam. Now that sounds very basic, but it's absolutely amazing and critical that you get the history in the patient's own words. I know a lot of doctors who let someone else, some sort of assistant, take the history. But there's a filtering of those words, and the patient's words, they use the same words across multiple cultures. And in multiple countries where I've been helping patients, they use the exact same words. And then that physical exam. I can't tell you how many times I've seen patients who said, I've seen 8 different surgeons and you're the first person who ever laid hands on my back. We then do the diagnostic injections. Now those can be landmark guided, fluoroscopically guided, CT guided, MRI guided, or what I believe is most effective is the use of ultrasound. And then we do our therapeutic injections, and that can be steroids, it could be Serapin, it could be D5, lots of things that we can inject. We can do a hydrodissection. If we can decrease the scarring that's around the nerve, if we can push the nerve away from where the pathology might be, often that's all that's necessary to take off the tourniquet that's around the nerve and allow the restoration of blood flow. Maybe it needs a surgical release. Your diagnostic injections can identify that, yes, this is the problem, and therefore give the patient the best opportunity to be able to get an appropriate and accurate surgical release. We can do cryoneuroablation, where we actually freeze the nerve, but it kills the nerve, but it leaves the insulation there so the nerve can grow back along its normal pathway. And then we might look at peripheral nerve stimulation as well. So we're going to talk about each of these briefly, but where the lecture is today primarily just on making that diagnosis. So the first thing is recognizing pattern recognition. When the patient comes in and says, my face hurts here, the recognition that that's often infraorbital nerve will go a long way toward getting you to that right diagnosis. You need to do the physical exam. Are you recognizing the inspection, recognizing the atrophy of the leg here or the bulge in the abdomen here? And then one of the most important things, I think, I have the patient show me where it hurts. And I had a guy one day tell me that he had groin pain. And so I'm looking in the front of his thigh and feeling, and I can't find anything. And I said, I'm sorry, just show me where you're talking about. He points to his back right here. Patients know the names of their car and the parts of their car much more than they know the names of their own body. When you say hip, it can be anything. When you say back, it means anything. When they say groin or pelvis. So it's most important to have them show you where it hurts. Where does it start? What direction does it go? Because I promise you, I'm doing this 30 years, I almost never can find a patient who can actually draw on the little drawing where it's hurting. They can circle it's the hand, or they can circle that it's the head, but really drawing where it's hurting is very hard for them. And so and then the physical exam. Palpation of known entrapment sites, because normal nerves are almost insensitive to pain, but when you have these entrapped nerves, they can be exquisitely sensitive. What I call, you have to pull them off the ceiling after you find the right spot. And then the diagnostic injections. And this is what I meant by landmark guided. I often will use a little peripheral nerve stimulator to help me hone in on the nerve. Ultrasound, CT, fluoroscopy. And then this concept of hydrodissection. Literally, it uses fluid to dissect apart the tissue that releases the entrapment. Now, fluids can find that place of least resistance between the tissue plane much more effectively than you can do surgically. And it mechanically separates those layers. And it's very similar to what you do with a blunt dissection when you're making a pocket or you're skinning an animal in this case. Cryoneuroablation we've got a variety of companies now that make machines, and then what they do is you've got a gas that comes out through the center of the probe and expands, and that takes the tip of the probe to minus 70 degrees centigrade, basically, which kills the nerve, but it leaves that myelin sheath so the nerve can grow back along its normal pathway. And then we can use ultrasound to do peripheral nerve stimulation. So let's start with the head, the occipital neuralgia. The pattern is usually this occipital nerve, this back of the head pain. Remember, there's a tremendous amount of overlap between the greater occipital, the lesser occipital nerve, the third occipital nerve, the upper cervical facets, the AA and AO joint, whole variety of things, as well as trigger point referral patterns. When we're looking here, we'll see two places of entrapment. One is at the base of the skull, where the occipital nerve goes through the fascial sling made up of the trapezius and the splenius. And this is a very, very common site of entrapment. This is also where the occipital artery joins in and just wraps around the nerve. But there's also a more proximal entrapment site. As the nerve leaves the C2 dorsal root ganglia, it comes out through the foramen, it comes across the inferior oblique, heads medially and then laterally, and this is where the occipital artery joins in. So with your flexion extension injuries, there may be an entrapment because of the trapezius, but there may also be an entrapment because of the inferior oblique. That inferior oblique is visualized under ultrasound, and you'll be able to see the occipital nerve right on top of the inferior oblique. So we're going to look at that specifically. So when you're looking at the ultrasound, you can either come from above and count down, or come from below and count up. But once you find the C2 spinous process, you then move laterally, tilting the probe, aiming for the transverse process of C1 so that you're parallel to the fibers of the inferior oblique. And so here you see the spinous process. This one didn't happen to have as much of a bifid spinous process as we usually see, moving laterally, tilting, and you begin to see the inferior oblique being a very straight line. Now, this one is a little hard to see, so I'm going to run it once, and it's very fast, and now I'm going to try and take it back and forth. I want you to look at this area right here. This is the occipital nerve, and what happens is as you move cephalad, the nerve moves medially. If we go back down the other direction, okay, so we can watch the nerve moving medially as we go up, laterally as we come back down, medially as we go up. And so just to make sure you've got the right target, make sure that you're checking for that movement as you move up and down. And this is from my dear friend, Agnes Stogitsa. The suprascapular nerve is a very common problem of shoulder pain and will give you this sort of cap pattern of pain. The nerve has, again, two sites of entrapment, one at the suprascapular notch where it goes through and underneath the ligament. The second one, though, is at the sphenoglenoid notch, where the nerve innervates the inferior, the infraspinatus muscle. Most of the innervation of the shoulder comes just as the nerve leaves the sciatic notch, and that becomes the suprascapular notch. And so that becomes important when we're talking about the approach to this. Here you see the MRI with the nerve going through the notch, and you can see how easy it is for this to create an entrapment. So normally, and this is where I see a lot of problems, normally people are taught to put the probe vertically and perpendicular to the scapular spine. But when you're doing that, you're looking down not the suprascapular notch, but the sphenoglenoid notch. So instead, what you need to do is tilt the probe so that you're looking down the notch of the actual suprascapular notch. So not a terrible problem a lot of times, but if you're focusing on the sphenoglenoid notch, you're likely to miss the majority of the fibers going to the shoulder. And so here you see the notch, you see the ligament, the artery sitting usually right on top of the ligament, though in this one it was actually in the notch itself, which would increase, as you can imagine, the risk of entrapment. Ilioinguinal and iliohypogastric nerves. Again, in this groin area, we have a tremendous amount of overlap, and the genitofemoral, ilioinguinal, and iliohypogastric nerves will have a reciprocal relationship. If the iliohypogastric is large, then the ilioinguinal and the genitofemoral are often smaller. This pubic region can be innervated by either primarily the ilioinguinal or primarily the genitofemoral, and they will switch off, sometimes even in the same person. You might have one on one side and the other on the other side. It is a branch of L1 and L2 coming from the spine, coming across underneath the external oblique at the edge of the iliac crust, and then getting trapped again at the edge of the rectus border, and then coming down potentially onto the pubic bone, though you will often have the genitofemoral in that pattern instead. And so here you see the ilioinguinal, iliohypogastric. Here's the external oblique, and you can see how easy it is to get it trapped here. And so again, two places where the nerve can get entrapped, and then coming onto the inguinal ligament and onto the pubic tubercle. So to find this, we're looking for the ASIS, and then we're trying to look between the layers of the abdomen. So what you see is the ASIS, the anterior superior iliac spine, and now we've got the layers laid out, and the ilioinguinal and iliohypogastric nerves will be lying between, this is the external oblique, the internal oblique, and the transversalis muscle. Now, that's where we're usually taught to do the injections, but just remember, if your entrapment is at the external oblique, this injection may give the patient temporary numbness, but it won't fix the underlying problem. And in the same way, if you're looking at pubic pain and you're doing your injection here and miss that the genitofemoral nerve is the pathology. So if you look here, this is the genitofemoral nerve on the psoas muscle, splitting into the genital branch and the femoral branch. And so that genital branch will often innervate this area. So doing injections at the ASIS won't make that pain go away if the problem is the genitofemoral. So you just need to be aware of where the reciprocal actions of these nerves. So, and here we have, again, this is my buddy, Dr. Stogica, who is looking at, you can watch the nerves moving back and forth as she moves cephalad and caudad. You can see the nerves coming in that fascial plane, and with the ASIS here on the right. So the anterior abdominal or cutaneous nerve entrapment, ACNE syndrome, can cause a wide variety of pain problems, and it really depends on which of these branches of the nerves are getting entrapped. What happens is these are the thoracic nerves. They come around, and just like we talked about with the ilioinguinal, they get trapped at the edge of the rectus border as it pierces through the rectus border to enter that six-pack on each side. And so here you see the dissection we did where the nerves are coming in. This is the edge, the lateral edge of the rectus border. Here we've taken the fascial sheath away. This was a dissection we did in Budapest with a wonderful anatomist, Gabor Basura. And so these nerves, because they have to go through this canal, can get trapped right here at the edge of the rectus border. So if it's on the right, it may mimic gallbladder or appendicitis. If it's on the left, it may mimic the spleen or diverticulitis. If it's down bilaterally down low, it may mimic endometriosis or interstitial cystitis. So you've really got to have a high index of suspicion for this particular problem. And so on the physical exam, you're going to take your hand and just run along, find the edge of the rectus border, and then just run cephalad and caudad, and you'll feel just a little half moon defect either at the level of the umbilicus or about 2 to 3 finger breadths below and about 2 to 3 finger breadths above. So it's a very specific and reproducible site of pain. And so again, really important to have the patient point with one finger where they hurt and in that, or where it started, if they've got generalized pain. And so then you put your probe on the rectus itself, and then you just move the probe slightly laterally till you get to the edge of the rectus, and you'll then see the external oblique joining on to the edge of the rectus. And so here you see the rectus abdominis. You'll get the double layer of the peritoneal pleura, abdominal peritoneum. Often you'll see the gut moving around here. And then, so this is the rectus abdominis. And as we move the probe more laterally, we start to see the rectus narrowing down. And then this is where you're going to find the entry of the blood vessels and the nerves there at the edge of the rectus border. And so here you're going to see, this is the rectus here. We have the rectus here. You start to see just a little bit of the double layer. And then as I move more laterally, you start to see this narrowing, and this is going to be the area of your nerves here. And so if we look at the Doppler, you can start to see here in just a second the blood vessels that are in this area. And with those blood vessels go the nerves. So the lateral femoral cutaneous nerve is a common cause of anterior lateral thigh pain and burning. And this lateral femoral cutaneous nerve comes out from the lumbar plexus. It goes underneath the inguinal ligament. It comes onto the, either it goes under the ligament, through the ligament, or on top of the ligament. It then goes over or through the sartorius to innervate the muscles along the lateral aspect of the thigh. And depending on where you're seeing it, you either see a large rectus femoris and a small sartorius, or a larger sartorius and a smaller and a tensor fascial lata. But we're looking at it usually doing under ultrasound the injection here. But you need to pay attention that the entrapment is often more proximal. So this is one of the reasons why I sometimes see this ultrasound injection failing if you're doing it in the standard position. So here's an MRI that I've colorized, and you see the sartorius, the rectus femoris, the tensor fascial lata, and the lateral femoral cutaneous nerve. And this is often triggered by things like pregnancy and obesity, because the nerve, which is coming along the edge of the abdominal wall, as that wall starts to drop down with gravity, you start getting a traction on the lateral femoral cutaneous nerve, and that traction and the entrapment as it gets kinked here causes pain. And so you'll see the nerve here you have the sartorius, the tensor fascial lata, and the rectus. femoris. And as we move a little bit further down, you see the classic shape of the sartorius, this cat eye area, that potential space between the muscles for the lateral femorocutaneous nerve, and then the rectus femoris at the and the tensor fasciolata, rectus femoris and tensor fasciolata here. And so this is again one of Aggie's ultrasounds. So you see the nerve here, you see the sartorius, and then the rectus femoris and tensor fasciolata. And so here, often we'll see do a hydrodissection. This is again Aggie's, where she's using the needle around the nerve and using fluid to get above and below the nerve to release the scar tissue around the nerve. And then we have the infrapatellar saphenous nerve, which is really one of my favorite nerves. This is the one my staff calls the Lourdes nerve, as in the place of healing in France. This is a nerve that will cause an anterior lateral knee pain, anterior medial knee pain, sorry, but it may cause pain in the lateral area. It may just cause this whole anterior knee. And this is one of the few times when the patients really can't point to where it hurts. It just hurts in the whole knee. This is triggered by surgeries such as an ACL repair, arthroscopies, total knee replacement, and if you Google Trescot and IPS, you'll see an article I wrote on taking the surgical literature, multiple articles that have been written by orthopedic surgeons doing dissections, showing that their incisions put that infrapatellar saphenous nerve at risk. And yet I have yet to find an orthopedic surgeon who's ever even heard of the nerve. So if you don't know about it, you can't avoid it. And as a result, these patients have a lot of pain postoperatively, but it's also the major innervator of the knee. So just like when we have somebody with facet pathology, we could do an intra-articular injection in that facet, or we could look at the nerve that goes to the facet. And most of our treatments are now on the nerve that goes to the facet, the medial branch. And so you'll see here, the nerve comes over or through or above the infrapatellar over the sartorius muscle, comes down onto the medial plateau fossa of the knee. Under an MRI, you'll see it wrapping around the medial flare of the knee. And so those of y'all who have been doing genicular nerves realize that if you look in an anatomy book, there is no such thing as genicular nerves. They're genicular arteries, but each of these nerves has a name. So the nerve that you might have been targeting below in the medial inferior portion of the knee at the tibial flare is actually the infrapatellar saphenous nerve. But it has a very variable location and anatomy. And this is why I think that the treatments under fluoroscopy are likely to fail, because very often the nerve isn't where you think it's supposed to be. So this is probably the absolute easiest nerve to find under ultrasound. So if you've never done ultrasound, I'm going to encourage you to try this one. This is the tibial ridge. So you just place your probe parallel to the tibia, just on the medial border of the ridge. And then all you do is move cephalad until you start to see the flare. So you're going to move the probe cephalad till you start to see the flare, and then just move medially, and then optimize until you can see the nerve. So here we see, this is the tibia, nice white straight line. If I'd started back further, you'd have seen it as a straight line. And then as I move cephalad, you start to see the flare of the knee. And then as you move medially, there's the nerve right there. Posterior tibial nerve is a very, unfortunately, common cause of heel, arch of the foot, bottom of the foot, ball of the foot, and toe pain. And this posterior tibial nerve travels through a tunnel very similar to what we see in the hand, the carpal tunnel. And so this is called a tarsal tunnel. And the posterior tibial nerve will give off the medial calcaneal nerve that goes to the heel, and then splits into the medial plantar nerve and the lateral plantar nerve to then travel underneath the bottom of the foot. But this whole area is filled with blood vessels and tendons. And so it's not surprising that the nerve gets trapped in multiple areas along this region. So under ultrasound, it's a pretty easy ultrasound finding, because once you get parallel to where the nerves would be and parallel to the ligament, what you'll see is a brain, artery, vein combination. And this is these three vessels will stay in this area, and the nerve will be very often either above, below, or beside this vascular combination. Now, if you're trying to look at things that are going outside or not in the tibial tunnel, or if you're trying not to put something in the tarsal tunnel. So for instance, when I'm doing stimulators, I won't put anything in that tarsal tunnel because there's not enough room. So I'll trace the nerve back more proximally to do my treatments away from where the nerve is potentially entrapped. And so here you see the nerve with the artery and vein around it. And so you can see the pulsations of the vessels and the relationship between the nerve and the vessels. So peripheral nerve entrapment can cause a variety of pain conditions, including headaches, facial and neck pain, chest wall pain, upper extremity, lower extremity pain, abdominal pain, as well as low back pain. The history and a directed physical exam followed by diagnostic injections are key to the successful diagnosis and treatment of these entrapments. If you're not familiar with ultrasound of peripheral nerves, and most people are treated with anesthesia, who are trained as an anesthesiologist or are used to looking at the brachial plexus, big combinations of nerves, but these entrapments are very small nerves. If you've been trained physical medicine rehab, you're good at looking at joints for pain, but you may not be as familiar with nerves. This little book, 90 pages, is really a wonderful resource to teach yourself the peripheral nerve ultrasound. And so each page has where the probe should be, what the anatomy is, the prosection, what it would look like under ultrasound, and what it looks like under MRI. And so they'll work here, and then they'll look at it here, and then they'll look at it here, and then they'll look at it here for both the upper extremity and the lower extremity and some of the chest and pelvis. So a nice little book. I don't get any royalties from it. This is my book, 900 pages of peripheral nerve entrapments, and about 77 nerves that we looked at from the head to the toe. And in this, each chapter has the picture of where the patient would be hurting, the pattern of pain, the physical exam, the differential diagnosis, the diagnostic tests, the landmark guided, ultrasound guided, fluoro guided injections, the surgical approaches, how you treat, how you prevent or moderate the entrapment, and then the potential complications for the treatment for all of those nerves. So this one I also get no royalties from. And so if you're interested, if you would like to email me, I'm happy to send you a link to the book. I'm just trying to make sure that people are getting the right education so that their patients will get the right treatment. And thank you very much.
Wow,
Stop sharing my screen.
Wonderful lecture, Dr. Andrea. Amazing, as usual.
Thank you. I appreciate that.
Can we ask some questions? We have some
Absolutely.
questions. Okay.
Absolutely.
So let me just read some of the questions that were raised here, coming from Dr. Samir Kumar Shah. The question is, how common is neurolipoma causing acne? I have a patient who has pain there in the epigastric region.
Yeah,
go ahead.
It certainly, depending on where the lipoma is, can certainly entrap it. And so that would be an external compression of the nerve somewhere along its path. So if you have a high index of suspicion of it, then you'll get a chance to treat it. So I had one gal who had had 8 laparoscopic surgeries for endometriosis. And every time she had the surgery, she'd get about 2 weeks of relief, and then the pain would come back. And they had lasered her and dissected and taken out her uterus and really almost done a just an evisceration of her. And when I asked her, show me where it hurts, she pointed with one finger right by the umbilicus. We injected that, pain went away. And what I think happened is that every time she had the distension of the laparoscopy, it stretched the muscle and relieved the spasm of the muscle that was causing the entrapment. So we've ended up doing a cryo on her, and she's, I think, 3 years out now. So
Great, very nice. There's another question here. It's about the lateral femoral cutaneous nerve. If the nerve division results in a smaller diameter, how to compare two sides to say that there is neuropathy?
You can, I don't think size necessarily tells you the information you need. I'm a firm believer it's the diagnostic injections. I will, however, remind you that where you're likely to be looking is distal to where the entrapment might be. And so though you saw Aggie's in-plane injection, which is obviously much easier, because I think the entrapment is more proximal, I will do an out of plane parallel to the nerve. I'll sometimes even thread a catheter up underneath the inguinal ligament where we really can't see the nerve very well, but where I think most of the entrapment is coming from. And so a little bit different approach. So I strongly recommend you start out with the in-plane because it's obviously so much easier. But I do a lot of out-of-plane work because I'm trying to be parallel. And when I'm looking at doing my nerve stimulation, I'm parallel to the nerve. So I encourage people to start with an in-plane, but get used to doing the out-of-plane approach, because for me, that out-of-plane approach is critical when you're trying to thread an electrode up the path of the nerve, or you're trying to put a cryoprobe, laying the cryoprobe on the path of, on the totality of the nerve, rather than perpendicular to it, where you're going to get less in the way of contact.
Okay. I have a question for you, Dr. Andrea. If you're diagnosing a patient with double crash syndrome, where would you start your hydrodissection dissection?
I start peripherally. You can't, you have to do, it's, if you've got a river dammed at 2 places, you have to relieve the peripheral, the distal one first. You will often get enough water going down to supply what you need. It's only if you've done the peripheral one, and I mean the distal one, and you're still having some symptoms, that I start looking cephalad. But I also recognize this is again where size may not be such of an issue. It may not look like that nerve is very entrapped because it's got entrapment proximally too. Mm-hmm. So it doesn't need a lot of entrapment distally if it's got entrapment proximally to be symptomatic. But it also means it doesn't require a lot of treatment distally to improve blood flow. And so I always treat peripherally first because the pathology won't get any better if you don't treat peripherally. If you're still having problems, I then make sure I'm looking proximally for that second entrapment.
I see. Would it matter if you are treating a patient with numbness versus a patient with pain?
Numbness is a later finding. I do a lot of peripheral neuropathy work. And so it is very gratifying when the patients start having feeling in their feet again after you've done the diagnostic injections. It's harder to treat numbness because you put a local anesthetic in and they are numb, but they were already numb, so it's hard for them to sometimes tell. I'll use a lot of the D5 at that point because I look at these nerves as being ischemic, and if they're ischemic, if I can give them nutrients like the D5, then I'm going to be more likely to be able to get them early response. So it's sort of like starting CPR on somebody, trying to get the blood circulating again. So that combination of a hydrodissection and using the D5 has actually has been shown in a couple of studies to be more effective than the steroids even. So are they you know, I always do steroids first. My thought is there's an inflammation, but the D5 may is my second drug to use if they got relief from the local anesthetic, but not from the steroid, or if I think there's an ischemia of the nerve to the point that the nerve is numb rather than hurting.
Good. Dr. Colin Chong from Australia has a question. Colin, go ahead. Colin, you can.
You're still, there we go. You're unmuted. Yes, sir.
Go ahead. He's an MSK radiologist from Australia.
Oh, lovely.
Okay, go ahead, Colin.
Hi, can you hear me?
There we go. Gotcha. Mm-hmm.
Thanks for the great talk. I've just wanted to ask, so I tend to use pulse radio frequency ablation for peripheral nerves, continuous RFA for spinal nerves, medial branches, lateral branches, and so on. I tend to use cryo for tumors or Mortons. And I know that I think the USA, if I'm not wrong, quite a few people use cryo for peripheral nerves. And I guess, you know, it's interesting because I hear different views on it. I mean, I love cryo, but I don't use it a lot here because it's very slow. Doesn't mean it's not good. It's a very good modality. But what I want to know from you is what are your experience regards to the efficacy between cryo versus RFA for peripheral nerves?
So, in the United States, we can't do pulsed RF because it doesn't have a code. And so my experience with PRF is relatively limited. I've been doing cryo though for almost 30 years, I think. And the cryo machine you have for the tumors is a much bigger probe than what we're using for nerves. So that's one problem. And are you using the arginine, or argon gas, or what gas is your cryo machine using?
Oh, so say again.
So what gas is your cryo machine using? Usually they're like argon or something along those lines.
Yeah, that's right, argon and helium, yeah.
Right. So these cryo machines are using nitrous oxide. It's a 2-minute freeze, so it doesn't take very long. They've got built-in nerve stimulators, and it's a much smaller probe than what they're using for tumors. So I think unfortunately, a very different approach. Now I know David Prologo at Emory is using that same tumor probe and using it for peripheral nerves. It is, I think, the thing I like about it is that, first of all, with pulsed RF, we really don't know what it does. And all of us know that there are people who get good relief, and doctors who use it and it works great for them, and other doctors and you use it and it just doesn't. And I actually had Schluter sat me down at breakfast one time because I was headed to DC to do lobbying for various codes in the US, and he wanted us to get a code for pulsed RF so he could use it in the United States. And so he sat down, in about 30 minutes, he's trying to explain to me how pulsed radio frequency worked, and really couldn't do it. But I can show you animal studies looking that nerve, it kills the nerve, it leaves the insulation there, and that we've got animal studies now showing that you can freeze that nerve they did it up to 32 times over the course of a year. Not only did the structure of the nerve come back, but the function of the nerve came back, which was, and I think it gives you just that prolonged period of time when the peripheral edema that's causing entrapment. Like, I really love cryo for CRPS because you've got this nerve pathology, and the nerve pathology creates a neurogenic edema, which causes more entrapment of the nerve, which leads to more sympathetic response, which leads to more problems. If you can shut that down for a period of time, it's fascinating. I don't even do sympathetic blocks anymore because all I do is the peripheral nerve, and all the edema will, and pain disappears. And so if it comes back, I then cryo it, and then they get 6 to 8 to 12 months of relief. The nerve grows back, and when the nerve grows back into a normal environment, it grows back normally, and then they get permanent relief. So I understand your concerns about cryo, but I think the biggest concerns are the fact that you're taking a machine that was designed for a different process and using it for that, another process. So if you're interested, I can get you contacted with some people who have a machine there in Australia that might
No,
be useful.
sounds good. I think you're right. I mean, it sounds like a very different machine. I haven't used cryo at all for the peripheral nerve of motions, like I say. I think for the same reason, because if I do use the machine that I use currently, you know, I'm not, I don't want to destroy the nerve, you know, but it sounds like the one that you use.
Yeah, your machine takes it down like minus 100 degrees.
Minus 40, yeah.
Minus 40,
And,
yeah. The minus 40 is fine. It's the minus 100 that ends up destroying the architecture.
Yeah.
So these cryo machines are sitting between minus 60 and 70. So, so something to think about. Anyway, you know, I'm happy to talk to you offline, and you just email me and I'll get you some information on the machine.
Sounds good.
Okay.
Perfect.
Thank you. Who else? Anybody else?
I have two more questions here.
Yes, sir.
It's a Morton's neuroma with, he's trying to ask about the difference between Morton's neuroma and intermetatarsal bursitis. How to find out which is the cause of pain?
Well, what I do is partially on the physical exam, and it's a little hard for me to do because I need a third hand. But basically when I'm examining the foot, I squeeze it this way to create the entrapment and then squeeze in between the inner spaces. So if you do that and you get a paresthesia to the toes, then that's usually where your target is. And then under ultrasound, ultrasound and fluoro, under fluoro, you'll see there's often that the metatarsal heads are hitting each other. And under ultrasound, you'll usually see the thickening of the nerve there. To be honest with you, I think even if you had a bursitis there, it is likely to be entrapping the nerve so that you've got the bursitis making less room for the nerve, but the pain that they have almost always is a neuropathic pain. And so I would base it more on the symptoms than anything. So if the bursitis is creating an inflammation, is creating a space occupying lesion, it's going to cause entrapment of the nerve. The nerve entrapment may be secondary to the bursitis, but the symptoms are usually from the nerve, in my experience.
Yeah. One last question is, I think this was already asked, how to differentiate between a distal or proximal entrapment?
It is the proximal one that sets up the conditions. It's the distal one that causes the symptoms. So it is the proximal one makes the distal area more susceptible. Think of it as a susceptibility, but it's the distal one that causes the symptoms. Does that make sense?
Yeah, very nice answer. Very logical answer. Okay, Dr. Andrea, we appreciate you for your time and for your lecture, very wonderful lecture.
Thank you very much.
Looking forward to you again. Actually, Dr. Andrea is also the head of the Pain International.
Yeah, Pain School International. And so I really should be, we've put everything on hold, obviously, because of COVID, but Pain School International, if you look at painschoolinternational.com, we have an executive pain fellowship. So over 4 weekends, we cover every pain procedure, really, from head to toe. It is very intensive. You get reading material, intensive didactic, hands-on with cadavers in Budapest. And what makes Budapest unique is the access we have to fresh cadavers. These are people who died the day before, and the tissue is often even still warm. So it feels, it's not frozen, it's not fixed. It feels like normal tissue. And so you get an opportunity to feel what it would feel like in a real person. And we cover fluoroscopic procedures from the head and trigeminal SPG, cervical procedures, stellate, cervical epidurals, cervical facets, thoracic epidurals, thoracic facets, intercostals, all the joints, all the lumbar procedures, including spinal cord stimulation, sacroiliac joints. And then, so doing the floor, we've got parallel tracks. You'll do, one day you'll do fluoro procedures, the next day of the weekend you'll do ultrasound, and then the groups flip on the alternate days. We've now had 17 students take either the FIPS or the SIPS or both, and all 17 have passed. So we're very, very proud. Dr. Stogitsa, Dr. Manzano, Dr. Fabricio, Assis, Dr. Edit Rax, Gabor Rax, and then we get internationally known lecturers who come to lecture and teach you at the cadaver. So Dr. Fabricio had come up with this idea 10 years ago and pitched it to me, and we started doing this in Brazil 10 years ago, and we've been teaching doctors there 25 a year. They go 1 weekend a month for 10 months. And now they have, up until COVID, they had 2 courses that were parallel. So 1 weekend was one course, 1 weekend was the other course. So 50 students a year going through Brazil. If you have a pain problem, go to Brazil. They've got the whole country. I mean, you can't go to a city and not have a well-trained pain doctor. I mean, it's just fabulous. Orthopedic surgeons, neurosurgeons, anesthesiologists, PM&R, radiologists. I mean, we've been training, and then we started 4 years ago with Pain School International for the rest of the world. So last year we had we've been training people from the US, Canada, Mexico, San Salvador, Brazil, Colombia, Argentina, Sweden, Switzerland, Poland, Macedonia, Hungary, Kenya, South Africa, United Arab Emirates, Saudi Arabia, Pakistan, Indonesia, Malaysia, China. But I don't know that we've had any Philippines. So maybe we'll change that.
We will change that soon, Dr. Andrea.
So painschoolinternational.com. Okay. All righty. Thank you so much for the invitation.
Andrea, yeah. So hope to see you soon in one of the meetings. And I could really say it's a very nice interaction with people from WIP and of course the Pain School International. So nice to have you tonight, and thank you very much, Dr. Andrea, and have a good day. Have a great day.
Thank you. Ciao.
Yeah.